Let me pull this picture up again. So that way when I talk about it,
So I mean, see, there are a lot of terms like the medical terms which I'm not following
That's
quietly
fine.
when you explain me.
Yeah.
So it would be good for me like if you can explain me my problem of like both for urine, what's the issue, and for neck, what is the issue, and for anus, like what's this? Just give a description and watch.
All right, I'll do my best.
Okay.
You're asking about 3 areas that are connected. Remember, the craniosacral stuff, that's one thing. That's more stability of your spine. But there's multiple things that affect that. So when you ask that, you're asking about like a lot of things with the neck. But generally, if you have a little bit of that skin that comes up, that's because the muscle tissue that slings around it is getting tight. So when it tightens, it's going to push that skin up a little bit. But the only reason it's tightening is because when this coccyx and sacrum starts to move backwards, it pulls away, which is gonna tighten that tissue line and pull it. And then you'll feel it on the right side of the anus. Instead of feeling a circle, you feel the right side. See how these are more single-sided? Well, that's a full circle. That's why you feel that, because this bone is moving away, because your sacrum is hypermobile and your sacrum needs to be stabilized. That's what I was saying since day one. This is the key to your symptom. Your symptom is not the problem. What it attaches to is the problem, and your x-rays got worse over those 3 x-rays. They got worse on your L5, and that was the sacrum moving. So that would be just that tissue line that you struggle with flaring. What is a flare? A flare is when you activate that tissue line with exactly what I'm saying, meaning you can do it seated, you can lift something up with a bad sacrum position, you can go to squat with a bad sacrum position. Any type of weight load that you put on your body where this bone is pulling away, as soon as you put weight on that, that's gonna flex. And when it flexes, that's the only thing that right now your brain is using this muscle to hold your sacrum forward. So if that sacrum moves backwards, it's gonna tighten this muscle, and that's gonna be the one loaded because of the seated position on the right. So for you, neurologically, your brain is programmed to flex this tissue to hold onto that sacrum anytime the sacrum goes out that direction and away. It doesn't have to be the full pelvis. Because if I sit right here, if I sit and my coccyx is underneath a little bit, it's right here. As I sit down on the pressure, it's gonna push it out.
Okay.
And that's gonna stretch it. Anything that does that to the sacrum will create your symptom. Whenever you say flare, you need to think of it as biomechanical. We have, because of what we went through and what we did, we have a very good idea of what this is. And if you maintain this position, it will not pull that. You'll have
sacrum needs to be above your coccyx bone.
Yes.
So right now it is pulling too much.
Yeah, it's hypermobile. It's moving too much.
Moving too much.
So it's not stable. If it was stable, it wouldn't fall out of position and pull on that tissue. It's not stable.
Just we need to strengthen it, and then muscle around it needs to be tightened.
All the muscles that hold the sacrum into position are the glute max, gluteus medius, all the glutes here, because if my sacrum pushes out that way, these aren't on. If I was gonna push my sacrum forward, I could externally rotate and squeeze my glutes and tighten everything around it. That's why glutes are not the sphincter. It's 2 different things.
So what we are doing is like we are positioning my sacrum to be pushed forward
in neutral
position.
Yeah.
So this is what the pelvic tilt is going to do.
Correct. As you strengthen the glute muscles
with your rehab that you provided me, that's going to strengthen it.
Yes.
Once it's back and muscle strengthen that, it's not going to pull back again. Like I'll be fine.
You have to keep it strong. If you sit too long after that though, if you go sit, you can degenerate it. If you sit for 8 hours a day, you'll turn your glutes off, you'll tighten up all the hip flexors, and you'll begin to create the same patternistic problems. That's why I said this is a symptom. It may be a high level symptom, it may be very bad, but it's still a symptom. And your problem, if you maintain that and you strengthen it, it'll be fine. Your hypermobility can only come back if you sit in a bad position and you stretch it, and you sit for 8 hours where it pushes the sacrum like this away, and you're sitting for 8 hours stretching it, everybody's going to have a problem.
Okay.
It's not just you.
Okay.
That's why I deal with males with pelvic floor dysfunction. That's why I work on different issues with sitting all the time, is because of exactly what we're talking about. Yours, though, is not hitting you and all the other stuff. It's because this sacrum is what's called nutation. It's moving too far forward on the top, which is it's a bone pulling the back away.
So that's what in the L5C1 or L5C1?
L5S1.
L5S1 that you found out in X-ray, like it is stretched out.
It's more spaced, yeah.
There is more space because of the sacrum is hitting it.
Like this. So this is L5. This is the sacrum. Okay, so this is the top of the sacrum. It's doing this. See the space? Instead of being here, it looks like that.
So that's a concussion injury that you said.
This is not the injury.
Okay.
This bone moving underneath is the problem, because this is moving too much. This is where it attaches the anal line right there, that external sphincter line. It attaches right here, and you're doing that. And so it's pulling that anal sphincter line as the sacrum gets moved.
Okay, the sacrum is pushing it, so that's why there is a lot of gap in L5S1. Okay.
That's right. It's because this is moving. It has nothing to do with L5.
Okay.
It only has to do with the sacrum.
So the sacrum is hitting the lower bone of the spine, and which is causing the most space in L5S1.
Yes.
Okay.
And L5S1 is not your problem.
Not problem. So
not at all.
okay, that's you found out when you saw it. Okay.
I just saw the biomechanics because of L5S1, so I know what it's doing underneath.
Okay.
Because if it's spacing out, I can tell you where that bone's moving. Okay. And if your symptoms aren't going away and your pain levels are very high and they're getting worse as it's going neutral, but the symptoms aren't going away, but you did a good job of taking care of the laterality problems, that means that if you don't take care of the sacrum flexion extension, you're going to have a lot of pain through here, because what you fixed is great. You just got to fix the sacrum part now.
Okay.
And but do you see what I'm saying? Like, that's a straight line anchor. It attaches to two things: the sacrum and the pubic bone. And what's going on is you shifted your whole right hip when you were sitting like that, so the whole line got hit originally, which created all your pain. But right now, you've already done a good amount of work that stabilized a lot. Just from the stuff that we're talking about, I can see the changes here. I'm not worried about this. I'm worried about that moving away, because you're sitting on a surface that's pushing the bone away from it. And then as that pulls, and you know what? Hard surfaces are worse, because a hard surface on a bone is going to create bone change directly. But a soft surface on a bone will move a little bit with a bone. But a hard surface doesn't move on a bone. It'll actually push your bone away, creating increased pain in the anus, even if it doesn't feel like your anus is actually directly on the wood or on the hard surface. But why is it hurting more on a hard surface? That's because your coccyx and your sacrum are being pushed away from the hard surface. If you tuck it underneath a little bit, that should feel good. But I don't want you to go too far, because just like I said, this is L5 and this is your sacrum. If you're here, I don't want you to go to there, because I said you're hypermobile. We need to go to neutral and strengthen it in neutral. Don't go past neutral and create a disc injury on L5S1.
Okay, how will we know like it's coming at the neutral?
Don't do this. Okay. See what I'm doing?
No. I mean, right now with all the rehab that we are doing, like it will go back to neutral.
That's what you're doing.
What tells you like, okay, we are going
about your lumbar spinal position?
Okay.
Because you don't have that little curve anymore. You're more straight.
Okay.
That little curve is present because you're tucking it out.
This curve, the
L5.
L5 curve. Okay.
Directly on L5.
Okay.
And I know because of your pelvic position. I know because of the rehab that we're doing and your symptoms.
But you're going to tell me like stop at one point, like where it is neutral or something?
No.
No. Okay.
You have to.
I have to.
Because I can't feel and I can't see inside your body, and no one can do that. There's no imaging. There's nothing you can do. You have to do that part, and that's why I'm saying you have to get that sacrum here into that neutral. And you can use your pelvis, but focus on the sacrum. Don't focus on the pelvis. Focus on this and get it to the right position. And once you take the sacrum here, not here, you take the sacrum here. My low back is flatter. I'm going to externally rotate my glute medius and activate my glute max to strengthen all of those tissues. Because the last part, you keep recording on this one too so you can see it. Pelvis, SI, and glutes. All right, so if this is your pelvis and that's your SI joint right there, your sacrum is that triangle in the middle. There's the coccyx, that's the anal sphincter, the tissue we keep talking about down here. If you see this part, you are trying to, if you internally rotate like this, the iliums, the bones right here, are going to internally rotate. It's going to take them out like that, creating more hypermobility in the middle. If it's closed down, it locks that sacrum into position. If it's open like this and you're internally rotating your femurs, it's going to open that up, and that sacrum has more free motion, which you're hypermobile. We don't want that. You need to set the sacrum in a good position and then externally rotate so it tightens up around these SI joints and these ligaments. After a month or two of you being in the right position, not sitting, not stretching it out, not creating a flare, after a month or two, these ligaments will become tighter. Okay. Then your joint is stable.
Okay.
But the ligaments are fibrous. The muscles are elastic. I care about you being strong. You need to hold that position for a long period of time so your joint can stabilize. You just need it to stabilize. That's why I keep saying hypermobile. Don't think about all the other stuff. Your hypermobility created your symptom. That's the key. Like all the other processes, it's true hypermobility is why you have your pain. So if you take away the hypermobility and you lock that in the right position and you hold that for generally a month and you're not doing things that are pushing it out of position and doing those things, then it's not going to stretch these ligaments and allow laxity and hypermobility. They're actually going to start to begin to shorten a little bit from the new position that they're sitting in. And as they tighten up a little bit in that new position, you restabilize your joint because the ligaments that are stretched out are no longer stretched out and they lock in a little bit. And when those lock in, you don't have to keep your glutes constantly on, you have to do constant rehab and all that. Now I am going to recommend that you lift weights consistently over time for health. And that just means, hey, load your hips, load your legs a little bit. The stuff I teach you in here and the stuff we're going over, it's the same thing you do while you lift. So if you just apply what I'm talking about with the pelvic tilt, diaphragmatic breath, external rotation, that pattern to lifting weights, then you'll never have to really rehab this. Again, you'll have other things that show up. And I'm pretty sure you'll talk about your right hip being a part of why you have other things show up. And I'll be like, this is coming from that. And you're like, oh, I thought we fixed that. But the sacrum and the anal sphincter won't be the problem. It's because you just got to, the white tissue has to stabilize. And now your glutes, look at how they run right into your SI joint. See that? You want to lock down that white tissue, activate those muscles, because remember when muscles contract, they go to the middle. So it's going to contract. It's going to tighten all of this up. It's perfect. That's what external rotation does for you, okay? I'm probably gonna give you one more glute activation external rotation exercise today, okay?
Okay, and what's the occipital neuralgia thing like? What caused it? It's because of this pain.
Well, I think, remember, there's two, stability first. That goes hand in hand. If you have this hypermobile, I know your cervical spine is hypermobile, okay? They go together. Remember the L5S1 is the same as O occiput, so O to C1. Mm-hmm. So this is the same joint as this, and they work together.
Yeah.
And if you want to pump your fluid, you pump them together. So when these two levels are hypermobile, and these become stuck, and these two act the same, and your sacrum is moving too far, I would assume that we're getting a little bit too much motion of the occiput too, and that goes back to the injury that you had, where you had the same symptoms as concussion or spinal cord injury. That's why I said that's a spinal cord injury. I'm pretty sure it moved inside. It's not that it damaged your spinal cord. It's just that it touched it.
Yeah, touched it. And
yes.
It was like the complete nerves on the top is like burning sensation. It came back again, like once after coming back here, my son hit ball and I reacted to it.
Yeah.
So suddenly like shifted my head towards one position and it flared up.
So that's this. So this is the structure. We just talked about what the symptom was, right? You hit the spinal cord. That's called myelopathy. Anytime you hit a spinal cord, it's going to give you symptoms on both sides of spasm. Spasming symptoms on both sides of spinal cord. That's what it is. So that's why I knew you had that, which also tells me your bones move enough. They're not stable, just like your sacrum. They're not stable, and so they hit your spinal cord, especially when you reacted and you pull them. So that's this. The structure goes by what's called the joint by joint. So let me explain it in an easier way. This one's good. All right, this is what these areas require. You need stability. You need in the cervical spine, in the thoracic spine, you need mobility. In the lumbar spine, you need stability. In the hip flexors, you need mobility. In the knees, you need stability. And in the ankles, you need mobility. If you did this, if you follow this pattern, like I'm gonna fix my body. If you did everything to do this through functional movements and lower cross and upper cross syndrome, and you just did all that only, you wouldn't have your cervical spine issues and you wouldn't have your sacral issue. This is the underlying full body pattern that you're dealing with. Now I can break it down to the individual anatomy and anatomical parts of it, like we're talking about your symptom and the sacrum and the biomechanics locally. That's local biomechanics. Now we're looking at macro, right? So peripheral. So that means that, okay, this is where my symptom is, and I know that's going on, but that area matches this area. And what did I have up here? Exactly.
The stretch that you told me, the thoracic
Sure.
stretch is
sorry.
going to
I meant like your symptom, like where you got that boom, the burning, and you had the boom, you had all that, because these joints move too much, and that houses the top end of the spinal cord.
Those were unstable on the cervical and also the.
Exactly. That's why I said you had hypermobile sacrum. Your biggest problem is a hypermobile sacrum. You've got to put it in neutral and strengthen it.
And after that, it goes to the cervical stability.
Right. Same thing, yeah.
With the exercises,
I'll give you some more before you go, okay? I'm gonna give you more cervical probably tomorrow, because I want us to clean up the rest of this a little bit today.
And how about the urination? The burning is like, because the nerve that connects to my right oblique is that you previously showed me something.
That was
urination issue is
the genitourinary nerve. That's because that genitofemoral nerve.
Can you show me?
Yeah. So, but I don't think that's what that is.
My pain and all the urinary.
I think the dysfunction is from that.
Or this.
It's hitting your nerves, so your brain can't feel it, so it's creating dysfunction. But also the tension that's in the psoas and all the deep tissues in here, I believe, are compressing, and as it gets tighter, it presses against the ureter, where the urine comes out of. And if it's tight, whenever your ureter, your urethra is tight, that creates burning. That's a burning feeling.
Okay. The pain strip sensation is like, is it related to the pudendal nerve is touching up somewhere?
Is that only on the right, or is it both sides?
I think it's on the tip. I don't know whether it's a right side, or I don't 100% sure it's a one-sided. It's all on tip of the penis is a sensation.
I would assume that one's more from the genitourinary nerve and branches from that. That's my theory on that one.
Yeah, whenever I bend or do these kind of activities in the past, like it used to come up just like that.
That's exactly what I think it is then. Because your psoas that we talk about, that's pulling your spine, that's creating your curve, that's making your sacrum worse, attaches to your hip flexor. The nerve that pierces it, genitofemoral nerve, comes down. Let's look up the genitofemoral nerve now. All right, so genitofemoral nerve. Let's see. All right, so we have, where are we at? I'm not showing much of it. Where is it? There we go. Lumbo-inguinal branch. Lumbo-inguinal branch of the genitofemoral nerve. Boom, boom, boom.
Oh, okay.
And testicle.
Yeah, it's on the testicle. It's a pull on the testicle to the right side of this. This is a part I always have an issue.
So you want to think nerve. Everyone wants to always think nerve. That's why I'm trying to tell you now. That's dysfunction. It's the fascia. It's the tissue.
Yeah.
It's the soft tissue run. See the striations? Well, why do the fibers look the same? Why are they running the same line? It's because they're a continuous pathway. And watch, it goes straight into your testicle. And I know this because I had testicular pain from this. So this, my psoas and my labral tear, my psoas created testicular pain. That's your psoas.
My
That's
psoas
not your
is
nerve.
okay.
That's why I think the in-third pain is probably some of the nerve. The testicle is not. That's going to be, it can be, but I bet it's more of that right hip.
Right hip.
And that's compressing your ureter, creating the burning, creating all of it.
Weakening your bladder.
That's right.
Bladder, and
yes.
I didn't have the force for the urine in the past now.
Well, if you didn't have the diaphragmatic pressure either, because remember, one more picture, let me show you another one. So, abdominal pressure organs. Man, I'm struggling to type today. I just haven't eaten yet. I need to eat.
Oh, you didn't have your breakfast or lunch? Or?
No, I was snacking, but not enough. I have a meeting right after you that I have to go to. I have to drive to. So let me see. I'm trying to show you this one so you can see. I have a picture of it. One sec. Let me find it. Okay. That way you can see what I'm talking about. This last part, I'll work on your hips and everything next. I need to go over the one new exercise I want to add in too. Okay.
Okay. We can do this tomorrow. It's okay.
Yeah. Well, there's one picture you need to see real quick. All right. I've got it. Here you go. I have a lot of pictures from pelvic floor because honestly, there's just a ton of questions that comes with it. You've dealt with it a lot. You talk to a lot of doctors and people say everything. So it creates a lot of questions, right? All right. So this is your diaphragm. This is the inside of your spine, or your body, obviously. Look at that curve. This person's got problems. If your sacrum looks like that, you got problems down here because all of it attaches right, boom, there to the bottom of the sacrum. So you are learning right now a good intra-abdominal pressure. You're practicing it with me and you're getting better at it. That's flexing the diaphragm, and that's now pushing down on all of the intestines, the organs. There's sacs called omentums around all of this. This is like a sponge or something that's filled with fluid. You step on it and it expands out. This is all soft tissue. There's no muscle. It's organs. So if you activate this muscle and you press it down, it's going to push straight down into creating bladder pressure.
Okay.
So your lack of activation pattern is because this hasn't been able to fill all the way low enough. The more pressure you get down on the diaphragm, pushing down to this, the more pressure you're going to press on that, and you don't have to use the detrusor muscle of the bladder. You can use your pressure how we're supposed to urinate. That's how men are supposed to urinate. We're supposed to stand, relax all the way, and then use the internal pressure to alleviate. And that's what actually gets rid of the full bladder, because your detrusor muscles will flex here. This will crush it down like a sponge. It's supposed to be like that. That's why the detrusor muscle helps it regain its shape. Why would it do that? Because it needs to. Because it's not that you want to use one thing or the other, but we end up overusing muscles here instead of using this to pressurize and urinate. Also, rectal pressure. So if the anus flexes and comes up and in, this pushes it down and creates rectal pressure, stretching the pelvic floor. Make sense?
Yeah.
That's you. That's what you need to work on.
Okay.
Okay, that's what we're working on that.
Okay.
All right, now